All right, so I'm going to talk about women in oncology a little bit off, but I think it's also an important topic. I'm taking excerpts from the Lancet Commission on Women, Power and Cancer, of which I was a co-chair. So, Women, Power and Cancer was the Lancet Commission. We published our results in 2023. We had a whole lot of collaboration with diverse multi-specialities, all the way down to basic scientists, to researchers, to clinicians in different, aspects of cancer care from different parts of the world. And we did include men to be on the first side. And what we found out was that of the 2.3 million women who die prematurely from cancer each year, 1.5 million could be averted through primary prevention, early detection, and deaths could also be averted everywhere if they were able to access optimal care. And accessing optimal care really can be a problem. So what we started with is to investigate the preventable burden of cancer in women, apply a more inclusive economics analysis to estimate the true cost of cancer impact on women, families, and society, to take stock of the missing women in oncology leadership, to broaden the evidence base to inform priority actions for a wide range of stakeholders, and to inspire transformational change in our approach to cancer. So based on what our findings, our recommendations were to develop, strengthen, and enforce laws to reduce exposures to known risks for girls and women, to research, monitor, and act on emerging risk and factors that disproportionately affect girls and women, to design and implement gender transformative strategies to increase equitable access to detection and diagnosis, develop a feminist economics approach to the investment case for other evaluations of cancer, to integrate gender competency framework into the education and training of cancer workforce, and to ensure equitable access to research resources, leadership, and funding opportunities for women. So I'm going to dive into the last line of my talk. Let's look at the current status of gender and practice in medicine. I'll say there's been the old tale of male dominance in medicine. It was conceptualized since our childhood. That's what we know. There's a lot of machoism, long arduous leadership tend to enforce these beliefs. The females in medicine most likely were in allied medical fields. Indeed, several studies have shown female role models have a domino effect. So once you have a female in a high position, it actually increases the number of females that are brought into the pool as well. Role models are most impactful in leadership positions. Unfortunately, females are judged according to your sex, let's intersect with your marital status, your ethnicity, your tenacity, and astuteness. So there's a lot of insights about women being sexually harassed compared to men, and then how well you can, withstand the bullying and across the trajectory of your professional development. Quite a significant number of women have descended the academic ladder temporarily or permanently because of all these issues. I'll talk a little bit more about. But without doubt, a gender diverse profession is needed to improve patient outcomes, to improve collective intelligence, and herald equity, across the care continuum. So let's look at the status of gender balance in oncology leadership. This was part of our findings of the Lancet. And you can see from the diagram I have here, the orange, which is Africa, Europe, and Asia, just shows that we are not doing very well with gender balanced leadership in oncology. Looking at 424 organizations within this region, for every 2 females, only 1 female was a leader. For the blue sections, North America, South America, and Oceania, for every 1 female, there was 1 male leader. So that means there was gender balance in these areas. What could be the reasons for this? We are not very sure, but this other graph below just shows you for the different types of organizations, looking at hospital, treatment centers, research institutions. Again, there were more males than females. The percentage was very low in terms of the number of females in there. Cancer societies, professional organizations, there were more males, For government organizations, there were more males. In private foundation, professional training, cancer registry strikes, again, more males. There were only more females where we had patient support groups, public charities, and advocacy groups. This shows to tell you how women are valued in what we bring to the table in designing cancer care. Now, according to the WHO, women account for 70% of the global healthcare sector. You know that a lot of the nursing profession constitutes a lot of females, but now the males are also coming in there and taking up the higher positions, in these nursing organizations as well. Women make up just 25% of the leadership positions, in spite of being 70% of the global healthcare force. There was an ISMO study that showed that the female representation on boards, presidents of national, international oncology societies, invited speakers at oncology conference remained below 40%. We did our study in the African Organization in Research in Cancer, and indeed, we are doing much better with more females in the leadership position and as speakers of our conferences. Approximately 10 to 16% improvement over 10 years. Can you believe that? Almost like 1% per year increment in spite of all the lobbying. There are very little, still we have gaps with leadership in authorship, editorial boards, clinical trial heads, heads of departments, and deans of medical schools. Female role models are needed to increase this role. Let's look at challenges in the gap. And this was a new ISMO Oncology Committee survey, and that was published recently in the ISMO Open, comparing 2026 to 2021. The problems that most of the women have that affected their career progression was the lack of work-life balance. It was equal male to female. The females are blue and the males are green. Lack of leadership development for female, of course, was higher for the female. Unconscious bias was for both. Societal pressures were for both. I think it would be a little different if it was Africa. Lack of female professional self-confidence was higher in the female. The males didn't think so, but I mean, that's quite obvious. Lack of role models, again, was a lot in females. Unclear career paths was equal for both. There was a lack of paternity leave. The men wanted more paternity leave. The women didn't think so. I'm not sure what happens during the paternity leave, but the women didn't think so. Insufficient maternity leave. The men also thought that was a problem because it means they had to step in, and that also causes imbalances in the home. And there are a few, when we asked the number that had no barriers, it was more for the males. They had no barriers compared to the females. So you can see that there are a lot of imbalances with gender and how you ascertain your career progression. So comparing 2016 to 2021 results, we realized that the most important difference was that maternity leave and difficulties in coming to work was actually much better in 2021. Financial constraints were better, and social pressures were better. So I can say that over the years, there has been some improvement of the survey comparing 2016 and 2021. But then how much better and how much did it actually improve the status of women in oncology? So we also looked at a study from Africa, led by Mutebi, looking at the barriers to progression of women and looking at the institutional barriers. Some of the respondents said, we don't have enough human resources, so we can't take a lot of time off. So when you have children, it's very difficult because you can't take that much time off. You have to come back to work. You can't bring your children to work. And then looking for help can also be a problem. So working arrangements go beyond maternity leave because outside of the maternity leave, these children need to be nurtured by their mothers, unfortunately, who are physicians. Now, the leave policies, for example, in Ethiopia, women are used to being housewives. The system was not designed to accommodate working mothers. Some people think less than 6 months is not fair. In some countries, after 6 months, you take unpaid leave, but that can also generate financial problems for the home and instabilities. So I think it's work in progress, but one of the recommendations is the government to institute fair maternity leave policies for women working in oncology. But in terms of interpersonal, looking at identity and value of women oncologists, for example, our patients think it's better to talk to a female oncologist. They understand and empathize when you have to discuss mastectomy versus a male oncologists who just you have to have a mastectomy. That's all. They don't have any discussion of how to cope. But with a woman, we tend to discuss why it is necessary. I'm also a woman. I wouldn't recommend a mastectomy unless it was necessary. And also to talk about the other things that you could do to improve your quality of life, like going for plastic surgery or using prosthesis. I think the men don't seem to communicate that to the patients as much. So you can see the impact of women in the clinics, especially for female. I think there was even a study for gynae oncology, which shows that the patients who were seen by female gynae oncologists actually did better. And the patients seen by female nurses actually tend to appreciate it better. So I think it's very important to include females into the work structure of oncologists, and it has to be balanced in terms of their life. Typical scenarios experienced by female oncologists. This was on the left, a study coming from India, showing that 33% of leadership positions are by females, which is unfair. 26% of the publications in the 2 leading oncology journals were authored by females. When it comes to corresponding and first authorship, only 26% of females were found as first or corresponding authors. And this study on a recent update showed almost the same findings. And the other problem is that most females are not recognized as an expert physician. You tend to be called a nurse or an allied health physician. It's even worse when you are in a minority ethnic background. When he looked at the award structure of setting oncology societies, they realized that less than a quarter of the females were awarded, even though they had the same job description as the men. There are huge gaps in research fund allocation from the NIH in terms of R01 grants, the quality of the granting also. So the higher quality grants go more to the males compared to the females, and also in the UK, Research UK research also showed again that females were actually disadvantaged when it came to fund allocation. In certain countries, you have huge pay gaps. The reasons are explained as: 1, there's less appreciation for the more work that you do, and also there's a bias towards high-earning referrals. So referrals such as breast cancer, gynae cancer, tend to have less earning capacity in terms of the insurance payments compared to the genitourinary cases. So that might be one of the reasons as to why. Fortunately, in Africa, we don't have this problem, but I think it's rife in other problems, and there's a lot of fights for that. In terms of the international graduates who are female, there was a cultural shock in that we realized that patients from other backgrounds tend to have discrimination 56% of the time, compared to 3.6% of the males from different ethnic backgrounds. I don't know why they tend to be picked on. I didn't want to say anything about sexual molestation, but it's also high. And also racial discrimination, again, was almost 70% in the females from other ethnic groups compared to 38% of males from other ethnic groups. So you can just see the disparities and unfair treatment that meted out. I was privy to an oncology, female oncology webinar, or say a roundtable from different parts of the world, and the concerns were the same as to how you tend to be undermined and you tend to be overworked, and the males tend to dominate over the profession. Unfortunately, looking at the divorce rate, I think oncology females tend to have a higher divorce rate. I think it's physicians overall. It's a little bit difficult. And unfortunately, what we also found was that 20% needed fertility assistance just to take care of the delays, because they need to put off childbearing, which is considered normal, to be able to progress in their career, which the men don't have these problems, and there's nothing in our policies to enable this. For those who did not have any children, 44% also would continue to want to delay pregnancy and consider freezing or cryopreservation of their ovaries. And indeed, in my deliberations with young other females, they also talk about looking for a job. When they come in pregnant or during pregnancy, somehow the organizations find a way of dismissing them from their work. And this is in high-income countries, not in middle-income countries. So this is something that we don't talk about enough. This is something that we don't advocate enough for, and I think we need to do more. We also found out that in a research that looked about patients, female physicians versus male physician burnout, female physicians tend to be burnt out twice as much or depressed compared to their male counterparts. And I'm sure the reasons are clear from my presentation. This is also a few studies that showing that looking at professional ranking of males versus females, full professor was higher in the male category, associate professor was higher in the female. So we tend to be given less prestigious positions in the profession. And when it came to the subspecialty choice, of course, almost it's like it's a must that you have to be a breast oncologist versus GU and thoracic and GI, unfortunately. But I hope that this will change as we muscle our way through this. There are good, there's good literature from the oncology education book that was published in 2023 on this subject, and a few other studies. Looking at the problems that the females face between academic and non-academic female oncologists, we realized that most of them thought family was very important. Career, the claim was not important, but career was more important for the academic oncologists and less important for the non-academic oncologists. In terms of personal growth, it was relegated for both, but more for the non-oncologists, non-academic oncologists. In terms of money, it was more important for the academic, non-academic oncologists. And then when it came to health, it was balanced between the two of them. It was actually number 2. But when it came to reasons as to why sacrifices for being an academic oncologist, less clinical time was more in the non-academic practice. So they thought they would have less clinical time if they became academic oncologists. And they will have less money as well. There'll be too much pressure for promotion. And time with loved ones was more of a problem for the academic oncologists. So there are so many plus and minuses as to reasons why a lot of women, in one study, in one of the ISMO studies, it showed that quite almost 10 to 20% of women considered leaving the academic profession because of the pressures that were relieved. So there were some recommendations based on the studies that I looked at, looking at different levels. There's also the gender competency framework, which I talked about earlier, that talks about sensitizing and educating the workforce into the importance of considering gender anywhere across the cancer care continuum. At the national level, there should be guidelines to promote gender equity. There should be equitable opportunities and award selection. I think that is very important. And wherever we are, we should promote this. I am known for that in my country. That wherever I go, I'm like, this is a panel. There are no females, or there are not enough females on the panel. I think it's something to really talk about. There should be government oversight of parental leave, wage transparency, and recruitment practices. I think the notion is just that females tend to take too much time off or always giving excuses. And I think that is something that needs to change. At the institutional level, there should be a task force to promote gender equity. There should be bias. It's unconscious, but I think it's something that we need to be trained to be aware of this. We need to have gender-specific leadership development programs because it's different for males versus females. Okay, and then we tend to have a more rugged time trying to climb up to the leadership ladder. And I think we need training to be able to overcome these. We need to have limit terms for leadership roles. So you have your head of department who's a male and there forever. So even though the female probably might be more qualified, you are not, you are not promoted into this role because of these limitations. We need to address the root of burnout. I know most of it is actually personal, but then there is an intersection in our social lives with our professional lives, and nothing can be done about that. And I think we need to learn to balance that out. At the individual level, we need the woman to be self-driven, okay, to increase professional development. We need to recognize and address implicit bias. That is a personal battle that you need to fight. We need to have effective bystandership. So that's also a big problem. Our women tend to stand by and not, volunteer and not proactively engage in professional activities. And we need to have male allyship. And they are the ones who will fight with you and fight for you to make this happen. So I think there are some men who understand the journey of the female oncologists. I think we need to harness assistance for societal female roles responsibly. So, for example, we need help. There's no way out. I always say it, and that's my personal experience, to take care of the household chores. I come from a society that is patriarchal. I can't do anything about it, but it's difficult for me to take care of the house completely while I try to improve my, achieve my academic goals. So therefore, I need help to take care of the home. And I think we should be prepared to do that, but we have to do it responsibly. Make sure you still spend time with your children, quality time with your children and your spouse and your family. We need to also drive mentorship groups and programs across the globe and publish trends, both positive and negative. And that is what will drive the advocacy. Right now, ISMO is doing a lot, but what are the rest of the other organizations and groups? There's a lot of publications at ASCO, but we need to get together to form allyship among us as a global movement to be able to address this change findings. We need to pull along and empower other females. It's very important. The males will not do it. And sometimes even while they are doing that, there are a lot of problems with that as well, in terms of power play and all of that. So we females need to harness more females, pull in more females into the leadership roles and even the academic progression. Thank you very much. So women actually we need to get over the glass ceiling. We can't go beyond it, but I think there's a lot of activity now. There's a lot of information now that can allow us to break the glass ceiling. But the problem is that we have a lot of limitations from the institutional level. And I think we need more women leaders at the institutional level to be able to break this glass ceiling. The sticky floor phenomenon is where we stay down, low down, because we can't balance our life. We can't take care of the children and take care. So the easiest thing to do is to just lay on the floor and stick to the floor without rising. I think we need to have self-worth to make sure that we overcome this. And then with the leaky pipeline, where a lot of that gets seem to give up along the line because there's no point in fighting, I think we need to fight, because we fight also for the future of other women in oncology. And the glass cliff phenomenon is when we get to the leadership position, we can't perform, we can't reach our indicators and our goals because we have so many setbacks. We need to overcome this and drive ourselves to higher heights. So with that, thank you very much.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.